Good morning, and thank you for letting me talk today. I come from a lab called Restore that focuses mainly on reconstructive efforts. This is one of our projects. No, nothing to disclose, standard military disclaimer. So negative pressure wound therapy has really revolutionized how we treat acute and chronic wounds. Just to put it in perspective, there's quite a few percentage of the population that has chronic wounds, which results in a mortality of 2.5%. It's a significant burden on society in terms of cost. In 1997, the first iteration of negative pressure wound therapy was developed. And this has really revolutionized our way of treating wounds. The mechanisms, which I'll go over, are listed there. So first of all, you have thermoregulation of the moisture by having this semi-permeable film placed on top. You have a sponge dressing that's placed in as a wound filler. The negative pressure allows it to drain excess fluid and inflammatory mediators. And also another mechanism proposed is that the really surface level, there's microdeformation, which leads to increased angiogenesis and granulation tissue formation. So where do we apply this negative pressure wound therapy? It's pretty much universal for all types of wounds, as you can see in this model. It's been used in open abdomens, chronic leg ulcers, as well as acute wounds, especially in trauma patients, which need temporary coverage. Two major types of foam available right now are a polyurethane sponge foam, pore size listed there, allows for even distribution of suction. It also fills the wound. There's another sponge, which is polyvinyl alcohol, which has a really slightly smaller pore size, used mainly over delicate structures. It's a little bit more hydrophobic and less adherent to tissue. So the main sponge used today is the polyurethane sponge, but has its limitations. So first of all, and most importantly, it's non-biodegradable, meaning that it has to be changed every 2 to 3 days, which causes excessive pain for the patient and sometimes requires take-backs to the OR for dressing changes. If it's left in and not removed properly, it may require surgical removal, which acts as a foreign body and increase infection. And it's also known to cause quite a bit of wound contraction. So the goals of an ideal sponge really is to have something that's bioabsorbable to prevent the need to have dressing changes. It's got to be, of course, biocompatible and biointegratable, and functionally comparable to our gold standard, which is currently the polyurethane sponge dressing. In addition, if it provided a scaffold to fill the defect and minimize wound contraction, that would be ideal, especially over surfaces such as joints. And if it did accelerate granulation tissue formation, this would be the next ideal sponge and the next level of wound care. So our sponges were created in two different manufacturing processes. Listed here, we did try a 3D printed version of polycaprolactone, which is pretty much used in suture material in terms of surgeons and also in scaffolds. We did treat them with different proprietary treatments, treatment A and B, to make the polycaprolactone more hydrophilic, because this is pretty hydrophobic in nature. So here's kind of the advantages of using polycaprolactone. Most importantly, it has a low inflammatory immune response. And degradation is by hydrolysis, and it's non-toxic degradation products. So this is our reason why we chose polycaprolactone. Just to look at the current standard of care, the polyurethane sponge dressing, you can see the pore structure there and the struts on the right. It's approximately 0.5 to 1 millimeters in pore size. Here are our sponges. Here's another scanning electron microscope of the sponges. So we have our initial point was a slightly larger pore size, and the struts are also pictured there. There's the untreated polycaprolactone sponge, as well as treatment A, proprietary treatment to make more hydrophilic, didn't change the structure, nor did treatment B change the structure of the the sponge pores. So the pilot study was really to see whether this was efficacious or possible to have the granulation tissue form and grow into these sponges. And so we did a pilot study. You have wet to dry dressing, which is the old standard of care. Polyurethane sponge is the current standard of care for negative pressure wound therapy. And we had an untreated polycapillary lactone sponge, as well as proprietary treatment A and B, and a 3D printed scaffold. So you see from post-op day 12 to 18 here, wet to dry, you have a lot of necrosis. It does heal, but it heals in a very contracted way. As well as polyurethane sponge, you can see there's much more high granulation tissue, which is why it's the current standard of care. It does cause a lot of, induce a lot of granulation tissue formation, but you do see by post-op day 18 quite a bit of contraction. When we looked at untreated polycapillary lactone sponges, they did not integrate. They were actually more like pushed out of the wound bed, as well as the 3D printed sponge did not incorporate well into the wound. However, with our treated sponges, you can see by post-op day 18 is completely incorporated into the wound, and the granulation tissue grew into the treated sponges. So this gave us great hope that this was efficacious, and we continued on with our main study, which we used 6 different swine. We also tried a different method where we tried double treatment using both A and B to see if that would increase the incorporation of the sponges. This is just a scanning electron microscope of the double treated, didn't change once again our spore structure. So this is our experimental. We had 6 different swine on the backs, 4-centimeter wounds in which we randomized where we placed the sponges, as well as the top had 2 growth controls. The experiment was conducted over 30 days, and then we looked at every 3 days histological evaluation, as well as use a tattooed area to assess for area of granulation tissue as well as contraction. So starting with our experiment, so wet to dry, you can see there's already contraction by post-op day 9. You can see some granulation tissue formation, but not significant compared to polyurethane sponge. So just proof of principle, the polyurethane sponge is a great way of wound healing and also creating granulation tissue, but once again, similar amount of contraction. This is by post-op day 15. The wound is starting to heal by secondary intention, and significant contraction, but both, you can see both methods are successful. But looking at our experimental sponges, so this is treatment A, B, and double treated. You can see by post-op day 9, you're starting to see the granulation tissue form into the sponge. You can see some peeking out, especially in B right there at the post-op day 9, starting to grow through the sponges and incorporate. And by post-op day 12, it's completely incorporated. You can see a lot less significant contraction as well, and a greater surface area of granulation tissue. Looking at the punch biopsies, you can kind of see that just from a gross view that there's completely incorporated. There's no gaps or of the tissue growing into the sponges. And from histological view, sorry, there's no exact stain to stain just polycapillary lactone, but you can see that there's granulation tissue cells growing into the sponges shown at the top. This is A, B, and double treated at post-op day 9. And we also looked at the 30-day study histological assessment. So you see wet to dry has a lot of surface necrosis on that upper left, as well compared to polyurethane sponge where there's a smooth layer of granulation tissue, which is excellent for wound healing. Our polycapillary lactone sponges, I'm just showing A and B here, did show a great amount of granulation tissue similar to polyurethane sponge, but there were some granulomas in that histological slides indicating some areas of where the polycapillary lactone sponges were still being reabsorbed. So just to look at it from a very close view, you can actually see on the upper left, the top, you can see some struts, and then the bottom, mouse, there we go. You can actually see this is a layer of granulation tissue just growing straight onto these struts here. So you can see it's fully incorporating here, as well as when you see even up closer, there's micropores in the sponges, and they're growing well into there. So showing that as biointegratable and biocompatible. So as mentioned before, the area of granulation tissue is increased significantly, which provides a better area for wound grafting, skin grafting, sorry, as well as less contraction. So just looking at the overall, so less wound contraction, more surface area for skin grafting. So conclusions, this is a bioresorbable, biocompatible, and biointegratable sponge dressing to bring the next level of negative pressure wound therapy, hopefully revolutionizing wound care. It's comparable to our current standard of care with this polyurethane sponge. It potentially obviates the need for dressing changes, and which will save the patient discomfort as well as multiple trips to OR possibly and a significant amount of money. And if it does continue to provide that scaffold for cellular growth, you'll have less contraction, which is ideal for especially over surfaces such as joints. And kind of the future directions for the study is really to, many variables exist, pore size, density of the polycapital lymph node, as well as using treatments or coatings to enhance either antimicrobials versus growth factors. So there's really lots of potential takeoffs from this point. Clinical applications, so we really need to use this on larger wounds. There's only 4 centimeters wounds. As you saw, they pretty much would close on their own by secondary intention, but we have to use larger wounds, which would have a difficult time closing and thus need skin grafting or dermal substitutes. And lastly, we really need to see about bacterial clearance. We didn't test it in this model, but these are left in, they're not removed. So we have to test to see if the bacterial burden is also cleared as well as what you see in negative pressure wound therapy. With that, thank our group and take questions.